and up and running. We're fortunate to be hearing about this topic today from the very heart of Tennessee Brighter Futures. You are probably invited to TBF by Wendy Elmo. And if you haven't already heard her speak about brain injury, then you are in for a treat today. I am very proud to introduce Wendy Elmo.
Thanks,
and
Jen.
I will stop sharing. You're welcome.
All right, and I'm gonna start sharing. Okay, all right. Thanks everybody for being here today. Like Jen said, we're going to talk about brain injury and how it relates to all of the other circles for Tennessee Brighter Futures. And so those are the systems of support. And back to this one, you've already heard that we are a grant-based program. We are funded at the federal level by the ACL, and we're funded at the state level by the Traumatic Brain Injury Program, of which Ashley Bridgman is the head, and she is likely on this call. I didn't get to see everybody that's here. And we are also a program of the Tennessee Disability Coalition. So what we're going to do today, things are laid out like those resource pages are laid out. So I'm going to talk to you about brain injury. I'm going to talk to you about why it's important to be identifying it within all of the other systems of support. We'll talk about screening tools, strategies, and accommodations for you all to use in non-brain injury programs. And we'll talk about referral options and other resources that are available. So types of brain injury. You can have a brain injury that is present at birth, or you can have an acquired brain injury, and that is made up of, that's kind of like an umbrella term for traumatic brain injuries, non-traumatic and degenerative things like the dementias. Concussion is a form of traumatic brain injury. It's a mild traumatic brain injury. And a traumatic brain injury is a bump, blow, or jolt to the head or body. So that also includes things like whiplash. Whiplash can be enough to cause a brain injury. It can also be a penetrating injury like a gunshot. And it's caused by all kinds of things like falls and motor vehicle accidents and violence, including abusive head trauma like shaken baby, also sports and blast injuries, which are common in veterans. And so a concussion, the way it's different from a moderate or severe injury is that it's considered functional, not structural. So you won't see anything on a CAT scan or a CT. If they use a CT finding, a CT scan, then what they're looking for is something like a skull fracture. That will turn up, but a concussion won't, because it is functional. It's a potassium-calcium issue. One should be inside the cell and comes out. The other should be outside the cell and goes in. And it's this chemical cascade that causes all of the symptoms. So we still hear today frequently, I didn't have a concussion because my CAT scan was negative. That's not a definitive diagnosis. There are lots of non-traumatic injuries as well. There's stroke, brain tumors, brain infections, seizures, any sort of way that oxygen is cut off to the brain through strangulation, drug overdose, drowning. We can have metabolic disorders that cause brain injury, poisonings that cause brain injury, and then of course an aneurysm or an arterial venous malformation. So we're really good. What we're going to be talking about today will relate to a lot of this, especially when we're talking about accommodations. If the brain has been changed, then the accommodations will work, should work for anyone, even congenital. If there are cognitive issues from a congenital injury, then they are applicable there as well. So I think that you'll find that brain injury is more pervasive than you may think. Every 9 seconds, someone in the United States sustains a brain injury. There are more than 3.6 million people that sustain that umbrella, an ABI each year. There are at least 2.8 million that sustained a traumatic brain injury, but we don't really know what that number really is because this is mostly ED numbers. It doesn't include when somebody goes to their general practitioner. It doesn't include veterans. So the real number is unknown, but it's bigger than that. So based on those numbers, about 68 Tennesseans experience a traumatic brain injury each day. By the end of a year, that is enough people to fill Bridgestone Arena in Nashville, where the Predators play, to standing room capacity by the end of a year. And at least 5.3 million Americans live with a traumatic brain injury related disability, and that's 1 in every 60 people. But we're going to kind of be adding to some of these statistics as we go. We chose a few case examples because it's what we deal with all the time. And this I'll put in quotes, Zach, is someone that we deal with all the time, where you have someone who is injured young, and then we quickly start to see some outcome from that. So this is Zach, and it's a few people put together. Injured at age 4, they're in an ATV accident, they have a loss of consciousness. Their initial Glasgow coma scale is an 8, and that means like it's not a great score. They're agitated, they're not able to speak, they're kind of moving all of their extremities, but not in a purposeful way. They have multiple skull fractures and facial fractures. The brain has shifted to the left. That could be because of cerebral spinal fluid. It could be because of swelling or blood. This is not a concussion. It is a big injury, but we hear all the time, oh, they recovered beautifully. Everybody, of course, thinks that this is wonderful. It is, that we really can't see anything afterwards. But then by age 5, they're failing in kindergarten. They're hitting other children, wandering around the classroom, disruptive, impulsive. No one identifies them as having had a traumatic brain injury. The teacher, even though very often these are big events within the community, it just doesn't get translated, and people just forget about it because they look so good. And when we interacted with the teacher said, it's just a boy being a boy. And it took the 3rd time when I'm trying to explain that these symptoms are very, very, they just go hand in glove with traumatic brain injury. In this one case, it took the 3rd time of me showing the teacher the picture of the child in the hospital with bruising, really unrecognizable, tubes everywhere, a picture of the car that was totally demolished, for the teacher to say, oh, I get it. But up until that point, they're just not putting things together. Another scenario that we see all the time is someone like Nathan, where they're injured young, and we don't really, not that we haven't seen things throughout the years, but it doesn't really get identified until years later when all kinds of things are happening. And we often hear these stories when we go out to talk, and people come up to us, usually the mother, and says, you're talking about my child. And it's then when the light bulb goes off. So at age 10 months, maybe they fall down a flight of steps, they're crying, there's no loss of consciousness. They're seen at the hospital and they say, oh, there's no concussion. Everyone is relieved. There are no recommendations except, to watch the child. Bruising around the right eye for weeks. By age 24, this child who is now an adult, is currently in prison. They're an addict. They've tried everything. We hear that all the time. Can't or won't hold down a job. It's kind of unclear. They're very smart, but they struggled in school. They have few friends, borderline personality disorder or some other mental health disorder. And usually at this point, the mom says, we get all excited and we're like, okay, here are some options. Here are some things that you can do. And the mom says, he won't get help. This is just who they know themselves to be. So they don't think of it can be anything different. Now, I've given 2 examples of injured as a young child, but you could still be injured as an adult and go on to have problems as well. Aaliyah was in a domestic violence situation. She was strangled multiple times and hit in the head way too many times to count. Trying to get on her feet in the shelter, but she misses appointments. She really has a hard time following the rules. kind of looks like she wants to violate the rules, isn't trying to follow them, can't tolerate the noise, sometimes sleeps on the street. JJ had a concussion during football practice. His grades are dropping in school now. He's impulsive, has a low frustration tolerance, which caused him to get into fights. He was arrested over the weekend for buying drugs. He's just trying to make his head feel normal, is what he says. John's been incarcerated twice. He has a high adverse childhood experience score. He had a brain injury in middle school. He started stealing. He went to juvenile detention where he sustained another injury, and he fell in with a bad crowd and started stealing crowds. Another example, James is in a substance use program. He says he wants to get clean, but he doesn't do what he says he's going to do. He doesn't participate when he comes to group. He seems to have a hard time paying attention. He doesn't seem interested. He was screened and found to have a history of a traumatic brain injury in high school. And then they took another step and did cognitive testing, and that revealed problems with memory, attention, and speed of processing. So we hear all the time, we don't see anybody with brain injuries. We haven't seen anybody with brain injuries. And we're here to tell you, they have seen you. They are in your program. Statistically, I'm going to talk about some stats in a little bit. And the stats tell us that they are in all of our programs. So we need to be thinking about that, identifying and helping them out. So we know that when a mild injury, that's a concussion level, occurs in preschool, then about a decade later, we see things like attention deficit, conduct disorder, oppositional defiance, substance use, mood disorder. When they're injured in later childhood, up to 16, and then about a decade after that, we see abusing substances, committing violent and property offenses. We see a lot of downstream things. And if you've had a brain injury, you're at much higher risk of having another injury. And then if you've had that second injury, much higher risk of having a third, and it just keeps increasing with more and more injuries. More likely to become obese, be incarcerated, abuse substances, become depressed, anxious, socially isolated, lower educational attainment, have a learning disability, speech and language problems, and bone, joint, and muscle problems. And if you think about with a traumatic brain injury, the way those injuries occur, they're traumatic to the body. So that makes a lot of sense that we'd see a lot of bone, joint, and muscle problems. And a lot of times it doesn't appear as a specific injury. Sometimes it's the head, sometimes headache, sometimes it's my shoulder hurts, then maybe it's the hip. And that's often attributed to the spinal alignment. Spinal column alignment is out. So as I'm trying to compensate for pain over here, I then push out something in another place and I get pain in another direction. There are lots of problems that we see after traumatic brain injury, and really because the brain controls everything, it can be anything. Some common ones are, they fall into these three buckets of physical, where we see balance and coordination, vision problems, walking problems. We see cognitive speech and language, slurring, forgetting words, difficulty responding, talking too much, just not being quiet, not talking enough. Very, very often problems with attention, and then also very often problems with executive functioning. And executive functioning is frontal lobe issues. That's our control system. That's things we'll see: impulsivity, difficulty starting things like getting up to go to a session, completing, getting a project started, planning, organization, judgment, can't self-monitor. I'm not aware that I'm speaking too loudly or I've taken over the whole session. And then flexibility, I can't change even if I do see something, it's harder for me. Behavior, we see impulsiveness, aggressiveness, rude, angry, belligerent, loud, don't know the boundaries, just not aware of them. And that can be even something as simple as standing too close. Nobody taught us how to, like, how far we should be apart from everybody, but we know what those rules are, those unspoken rules, and sometimes they'll stand way too close or way too far away. Usually it's too close is the one that we have an issue with. So now I'm going to switch and talk about the intersectionality. How does brain injury relate to all of the different groups that are part of Tennessee Brighter Futures? And I would encourage you to not just listen for yours, but listen for all of them, because we are all so interconnected. That's why we're bringing this group of folks together to begin with. So with adverse childhood experiences, we know that brain injury can be caused by some of those ACEs. So think about child abuse. And if you have had a brain injury in childhood, that can be an ACE. It's not going to show up on any of our quizzes or checklists for ACEs, but it can be that just huge event that changed your life and led to so much stress and anxiety that it can be it can be an ACE, or living with someone who has had a brain injury can be experienced as an ACE. Everything from knowing that, just learning that your parents are mortal, that is life-changing. We don't really think of that as a child. Or when you have an adult now who they now need all this attention, or they are abusive. You don't know, they're erratic. You don't know what's going to happen. That can be an ACE. The toxic stress from brain changes and ACEs lead to risky behaviors down the line, increasing the risk of TBI later in life. And then we know that toxic stress negatively impacts our overall health and our brain health. The connection to mental health. After brain injury, we really see an increase over the general population in all areas of mental health. We see social isolation, poor social skills, but we also see anxiety, depression, PTSD, aggression, oppositional defiance, obsessive compulsive, psychosis, paranoia. We see an increase in all of them. Brain injury can create mental health issues. So you have something huge to be depressed about or anxious about, but it can also worsen pre-existing mental health issues. Coping is much, much harder when you have a brain injury. Within 1 year following an injury, about 1/3 of the folks are going to experience a mental health problem, and that number will grow over time. It'll fluctuate a little bit too. You might get through your initial depression, but then you might have an issue that arises down the line. People with a brain injury have 2 to 4 times increased risk of attempting suicide or dying by suicide. And as high as 75%, this is a big one if you work in mental health or substance abuse, or see people in your program who do, as high as 75% of people who seek both mental health and substance use treatment also have a brain injury. So if you're working in one of those dual diagnosis facilities, 75% have an injury, brain injury. And because of all this, the recommendation from the ACL's Behavioral Health Guide says that all people seeking mental health treatment should be screened for a lifetime history of brain injury and provided with accommodations that fit those symptoms. And then if you want to take that next step and do voluntary cognitive screening, you can offer that as well. With substance use, 70 to 80% are discharged from a healthcare facility with a prescription for opioids after brain injury. They are 10 times more likely to die of an accidental overdose because they have problems with memory and judgment. Remembering when did I take something? How much did I take? Underneath the circle is a repeat of the stat that we heard on the slide before, that whole mental health substance use connection to brain injury. Half of the people receiving substance abuse people have at least one brain injury. So again, you're working in this population, about half have received at least one brain injury. I'm going to kind of modify that at the bottom as we go. I worked in a brain trauma facility for many, many years, and about 25% of those people that enter a brain injury rehab are there because of drugs and alcohol. Doesn't mean they were addicted. It just means that they were on drugs or alcohol when they were injured, probably contributing to the injury. I know I treated a number of roofers. They kind of stick out, but a lot of car accidents as well that were junk on the roof. And your brain can't recover as well when it's on a substance. Those with a childhood traumatic brain injury are more likely to abuse drugs and alcohol as adults. Okay, if I've lost you here because I've been throwing a lot of stats at you, I want you to come back for a minute, because this one, again, even if you're not in substance abuse, I want you to listen to this one. For every overdose death, and that number is big. There are approximately 50 overdose survivors. 1 death, 50 survivors. 90% of those survivors become impaired because of insufficient oxygen to the brain, or anoxia. So let's put that another way. There's about 1 plane load, and this is a 300-person airplane, that the analogy goes that crashes every day, and that represents overdose deaths. But now let's take that out. That means there are 50 planes, 1 for each state, each day, of overdose survivors. 45 of those planes, the people who walk off, are impaired, brain impaired, because of insufficient oxygen to their brain. If you want those numbers, it's about 106, 108,000 deaths per year, which means 5.4 million overdose survivors, which means about 4.9 million people who are impaired with brain injuries, just from substance use. Domestic violence. As many as 20 million women each year have a TBI caused by domestic violence. That's just women. And usually the target is the head, neck, or face in the assaults. And women who are abused are more likely to have repeated injuries to the head. Survivors of domestic violence are likely to have problems with cognition, attention, concentration, memory, that executive function, that guiding process, and the processing of information. So it makes it harder to assess danger, make decisions related to safety, and adapt to living in a shelter, among other things. And you always hear the question, well, why did this person stay in this relationship? And there's lots of reasons, but I never, even working how I do with what I do, I never thought of this, that, well, their brain isn't letting them look at the whole situation to say, this is dangerous, I need to get out, to look for triggers, to understand what's likely coming, and to make decisions related to their safety about, how do I plan to get out? How do I organize myself? How do I do all of those steps? So I thought that was really interesting. And then in Ohio, they've done a lot of great work in domestic violence. And what they found is that 85% of people within the domestic violence realm experience blows to the head. 85%. Of those, 50% were too many times to count. 83% experienced strangulation. Of those, 88% experienced it multiple times. So we see that those are both over 50%. So that means that people who experience both blows to the head and strangulation has to be higher than this 85%. And my guess is that it is close to 100. I don't work in that field, but that it would mean that somebody's only getting hit, below the head. And I don't know that happens a lot. So these numbers suggest that with everybody that we're treating in a domestic violence situation, we have to be considering that they've experienced at least a head injury and potentially a brain injury, because those are separate. Just because someone has experienced a head injury doesn't mean a lot of us have hit our heads and not had a concussion or not had ongoing symptoms. But we have to at least consider that it has happened. So when we're working in other areas, not domestic violence or not substance abuse, we have to be asking questions like, have you ever survived an overdose? Have you ever been in a domestic violence situation? Even if neither one of those things are occurring right now, it could be in their history. And so the brain injury could be in their history. If we turn to the justice system, within 5 years post-injury, about a third report some involvement with the criminal justice system. If you're in juvenile justice, about 40% have had a TBI. And that's high, and that's higher than people outside kind of working with the system have told us. They said, no, there's nobody in ours, especially on the legal side, there's nobody that has had a TBI. They're there, about 40%. And then they're likely to sustain more injuries, those juveniles, as they age. With a traumatic brain injury, they're at a 69% higher risk of re-offending. And that probably is things like that judgment, that impulsivity. In the adult system, studies put it between 50 and 80% have had a TBI. That kind of makes a whole lot of sense, at least to me. And people with a traumatic brain injury are 12 times less likely to achieve a release for good behavior. Again, probably impulsivity, judgment, behavioral issues, frustration, anger. And it's said that close to 100% of women in the justice system have a history of TBI, and that's attributed in large part to domestic violence. Homelessness, we're making it through our circles here, hang with me. I think this is really important to first understand our own system, but then to understand the interconnectedness with the other systems, how we're all related, which is why we're here. Over the half of those who are homeless have a TBI. Of those, 25% are moderate to severe brain injuries, which is 10 times higher than the general population. And they have poorer general health and functioning than people who are homeless and don't have a brain injury. If you've had if you're homeless and have a TBI, you're more likely to report childhood trauma and violence. And TBI can cause homelessness, and it's also a consequence of living on the streets. Chronic pain after a brain injury. Pain is the most common chronic medical condition reported by people with a TBI. And over half of the people with a TBI, and remember the numbers I said for that are huge, who have had a TBI, develop chronic pain, and they have more frequent headaches, which are likely to be medicated, more likely to be prescribed opioids. And then, as we mentioned earlier, the problems that follow brain injury make it harder to self-regulate the substances that they're taking and makes it more likely that they're going to overdose. And pain exacerbates other brain injury symptoms. So you all know that if you've been in enough pain, it's really hard to concentrate. Sometimes it's hard to hold a conversation. You wouldn't undertake planning or organizing anything big. And people with a traumatic brain injury are 11 times greater risk of accidental overdose. Child abuse, this is our last big circle, then we'll go into some of the social determinants of health areas. 30 to 60% of the perpetrators of domestic violence also abuse the child in the household, and they can be a result, the brain injury can be a result of any number of things, including punching, kicking, suffocation. And abusive head trauma also includes shaken baby, which is a devastating injury. It is, so it's literally shaking the baby, and it causes diffuse brain injury and can be catastrophic. Can be oxygen deprivation, swelling of the brain. The skull injures the brain as the brain rubs against the skull, which is not smooth in all places inside the brain. That causes damage as well. So there's also a disproportionate impact on people with disabilities. At least 5.3 million Americans live with a TBI-related disability, 1 in every 60. And acquired brain injuries puts that much higher. I think if we put, even though the anoxic injuries from substance use would put that, would be an ABI, I don't think that number is including that, because we know it's an even higher number. Some disabilities put people at a higher risk of sustaining a brain injury. If you think of someone with a balance disorder, a vision disorder. Veterans, more than 450,000 US service members were diagnosed with a TBI from 2000 to 2021. Many also have depression and PTSD, right? So again, we're looking at more than one diagnosis, and blast injuries are the most common cause in veterans, which tends to produce diffuse damage as well. And people in rural areas are more likely to die from TBI and have less access to care. Racial and ethnic minorities are more likely to have poorer outcomes after traumatic brain injury and less access to care. The elderly are the most likely to have TBIs in Tennessee, but also across the country. They're more likely to fall than other groups. and they're more likely to be hospitalized and die. And then, you know, my mom lives in an independent living facility for older folks, and she's constantly telling me stories of this one fell and they came back and they just weren't the same, and this one came back and they very quickly had to be moved to the next level of care or a nursing home, and many also died following their brain injury. Even if it was a concussion level fall, their brains are just much more susceptible. They're often not treated for their symptoms, and their symptoms are often attributed to things like dementia, or it's just natural aging, even though we might be able to treat some of their symptoms. Gender, men are more likely to, they have a higher incidence in young childhood. Girls with cell phones, young drivers with cell phones, women are kind of battling them for that. Women are significantly more likely to die from a head injury than men, and they're more likely to die from an injury from assault than men. Let's now shift into screening tools. And formal screening tools is really what we are looking for people to use. People will say, well, we don't have enough, we just don't have the time, but this can be something that you can give to the person. They can fill out. Some people might need assistance. If you say, well, I'm not going to go that route, I'm going to just incorporate questions into my existing intake. You can do that, but often you have to ask the question so many times in so many ways for them to go, oh yeah, that you might as well use a formal intake. And Dr. Amen, who is looking at brain scans, literally SPECT scans, seeing the injury, is saying to people, when did you have a concussion or some brain level injury? And they'll say, oh, I never did. And he knows it's there, he can see it, and he'll keep asking and asking. And he's the one who says, sometimes you have to ask 8-9 times before they finally say, oh, do you mean when I was on the back of the motorbike with my dad when I was 3 and I got thrown off? Like, yeah, but we just don't think of those things anymore, even though they may have contributed significantly to how our life developed. And we're happy to work with you to figure out which screening is the best and how to incorporate staff training and client education into your protocols. So some screening tools, there are some great ones available at nasha.org. This one here is birth to 3. We've got everybody covered, 3 to kindergarten, and then adult ones. This one is very widely used, the Ohio State University one. We recommend the OSU modified. It's modified to include acquired brain injury. So it asks questions about stroke and seizure and brain infections, things like that. At this moment, we're trying to get it up on the NASHA site, but at this moment, you would have to get it from us, right? or Pennsylvania, but us. Pennsylvania is the one that modified it. Domestic violence has one of their own that they have created, a screening tool. This also has accommodations built into it, which is really nice. And so let's say someone says, yeah, well, I hit my head, but I don't know if I ever had a concussion. Well, you can show them a symptom tool and see if they ever had any of the symptoms that go along with a concussion. It's just going to give you a general idea. These are all age groups represented, and the purpley one is for people who communicate without words. So if you're working with a nonverbal population, and any tool that is ours also has Spanish available, pretty much. Okay, so screening for a lifetime history of brain injury, that's what we're trying to do, is find out if there's been a history of brain injury. 2 other tools are, there's an adult symptoms questionnaire and a juvenile symptom questionnaire. Both have sets of accommodations that go along with it, which makes that a nice tool. So you can say, okay, well, they're reporting this problem, and here's some accommodations that can go along with it. All right, so again, if I've lost you, if you could come back for a minute, because I think that this one represents the opportunity to make some big change across the state. For $150, we can take master's level clinicians in any area, social worker, vocational rehab, I'm a speech pathologist, addiction, mental health, and we can teach them to screen for cognition. This is a national course that people can sign up for. And we can create the people, kind of the network of people across the state who can assess for cognition. So we could potentially do this in a lot of ways. And I'm really interested to hear what people think about this. So let's say we all start screening for brain injuries and we start finding them in our populations. We may be able to just go ahead and accommodate, but we may need to understand more about their cognition before we go ahead and do that. And if we have a network of people who can screen for cognition, we can then say, okay, here's what their problem areas are. And then we can get you, there's plenty of accommodations that can go along with that we can work with. So it's an opportunity to give us more information. It could be that, let's say, mental health has their own network and they show up at different, maybe they work within a clinic and they can handle just that clinic, or they are available to other clinics as well for maybe a nominal fee. So lots of different ways, or maybe there's a statewide network that maybe Tennessee Brighter Futures helps to keep track of, and we can use it across different circles of support or systems of support. So I think right here is a big potential to make change across the state. So, all right, why do you need to know about that? The fact that there's been a brain injury, big deal. They're there, we know it. The stats tell us that. We need to know because it's going to have an impact on your treatment outcomes. So take substance abuse, for example. We know that people with a brain injury they're going to have a harder time going through your program. And they're also going to need to come back to your program more than other people do. The cognitive changes and behavior changes make it harder for them to be able to participate. They're not remembering, they're not processing what you're saying fast enough. They're getting frustrated, and that's shutting down their attention and their memory. They're less able to maintain that improvement because they have to have some continued structure and support beyond, again, what is kind of normal for a program to be able to provide. And that's because of judgment and impulsivity and memory. So with all that I've told you about brain injury and all the changes that we could see following it, brain injuries are reasons why things are happening, why they're having some difficulties, why they're doing the things that they're doing. They're not excuses. So we still, within our programs and within our society, we need to have the rules, boundaries, requirements, expectations, and accommodations, because that is not coming from within, right? So for us here on the call, it would take a lot for us to break the law, right? We'd really have to be pushed in order to break the law, because we've got so much internally saying, no, don't do that. Stop and think about the consequences. Let's play that out. Let's not be impulsive here. Let's think of all the solutions. Well, that's not the case for people with brain changes. I'm specifically calling it brain changes because it's not just a brain injury. It's also brain changes from things like ACEs. Because that frontal lobe is impacted, we need rules, boundaries, requirements, expectations, accommodations within our programs. So some other things that we can do within our programs, we can modify our speaking style. We can speak more slowly. And this is without condescension, because they will pick up on it, especially if there's someone who's like, I feel stupid, I am stupid, people treat me like I'm stupid. If they come from that perspective, then you speaking more slowly to them will kind of make them feel like that's what you're thinking about them. We use simple, direct language. Keep calm with a low volume. Obviously, they need to hear you, but this is kind of coming from the perspective of people who have been involved in trauma, or people who have a low frustration tolerance, or that they don't have great behavioral control. Even if you come in really excited, like, hey, great to see you, that can put me above my threshold. And now I'm more likely to have a behavioral challenge of some sort. We need to give information in smaller chunks, repeat it as needed, and pair our talking, whatever we're telling them, with something in writing or something visual. So I worked in a brain trauma unit for 20 years, and I became the queen at reading and writing upside down. So I would flip the page, whatever I was talking about, I would flip it so that they could see it. And I could read if I needed to read it. I would circle things. I would write in comments that related specifically to them, whatever I needed to do. And so they had both of those things at once, because sometimes words just go on by. And also just handing someone something to read may also not be the best choice for them, but the combination is often good, or following up the spoken with something that they can see, especially if they're going to be distracted. If they are going to be distracted by what you're showing them, I would take a blank piece of paper and cover what we weren't up to yet, and just show them little by little what it is that we're talking about now. Some example accommodations, you can write things down for them, but we want to get to the point where we're getting them to take the note or to use the strategy, whatever it is. We want them to get to the point where they can use that strategy or accommodation. And I use those two words interchangeably, where they can do it by themselves. Set up alarms for appointments. Ask them to paraphrase it. Okay, can anybody tell me, especially if you're working in a group, what do we talk about? That gives that person an opportunity to solidify it, but it also gives everybody a chance to hear it again. If they can't paraphrase it, I would probably only try that one-on-one where you can jump in and help them out. Support efforts, their efforts, whatever they're doing right now, if they're attempting to use any kind of strategy, support that, give them positive feedback about that, and then help them to use it better. Maybe a notebook, a calendar, a list. Provide education. That can be life-changing to understand, I now understand why I do what I do and why I've done what I've done. I'm not stupid. I'm not bad. I had a brain injury. And help them with some brain injury resources, help them to understand it better. We also need to be educating our staff more about brain injury. With judgment and impulsivity, we need to help them to stop and think, plan ahead, anticipate triggers, outcomes, any kind of difficulties I might have, and plan for that. And then what are the consequences are if I do it this way. We need to help them to understand their injury and what the challenge is, but we have to be really careful not to just leave them with the problem. So, we do our testing and say something like, your memory, we'd never say this because we're used to working with folks, but your memory's terrible. We don't want to leave them with that feeling, however it is that we say it. So I want to try to use whatever they've told me whenever I can, because now it's not me telling them that there's something wrong. I say, you've told me that sometimes you forget things. I've noticed that you remember better when you use your planner. So I want to, if I'm giving them something negative, I want to be giving them something that they can get themselves out of that. Though there's a way to make it better. We need to get good at cueing them. So people with brain injuries can talk way too much and get themselves way off track. So we can say things like, oh, you were saying though, when you first came in here, you wanted me to know about this. And they'll often just go, oh, yeah, and come right back. If they're forgetting, I think you took notes on that. Get them to be getting into their systems that they're using. Do you have any appointments tomorrow? Cue them to be thinking about it. Did you set your alarm for that meeting? Did you set the alarm for an hour earlier as well when you need to be getting ready for it, right? Because by the time the appointment comes around, it's too late. Give positive feedback whenever you can. And what I try to do, like I said, is I want to use their words and what the problem is. And then I want to give feedback in the way that they want it. So I'm going to have conversations with them about that. So, right, sometimes I talk too much is what they've told me. I said, that's awesome insight. I can help you with that if you'd like. In the past, because sometimes this is not the first time we've talked about this. So that was an aside to you. No, I wouldn't say that to them, but I've said, oh, we we've talked about this, and you've said that it's okay that if I make eye contact and I kind of just raise my finger when we're in the group to let you know that you've made your point, you're good. Is that still okay? Because sometimes you'll get challenged. You're the nag. Why are you always telling me what to do? Oh, no, I'm sorry. I'm just telling you what you said was okay for me to tell you. If you want me to change, I want to help you. And I want to help you in the way that you want to be helped. So if there's a better way that you want me to do it, I will happily do that. And usually you get, oh, no. That's fine. That's fine. Or you change, or you come up with a different way of doing it. If they say, sometimes I forget appointments. Okay, how about if we meet for 2 minutes at the start of the day and we review what's happening that day? What if I help you set the alarms you might need? And again, we want to then back that off to the point that they're able to do that, and then give them that feedback for that's awesome. That's great. You've already got them all set. MindSource is a great resource for some of the accommodations pages. It has, even though it says cognitive strategies for community, mental health, criminal justice, strategies are strategies, and they help in different, lots of different situations. So what I would recommend doing is pick up all of the different accommodations resources that I'm going to show you and just get a sense, get people within your system of support thinking in terms of accommodations and strategy as a way to do something, not just getting people to do something, but how are they going to do it? How are they going to get there? These are some other accommodations tools. The CBERT one, Center for Brain Injury Research and Training, was developed for the school system. I love that tool, even if you're not in a school system. Again, it's just great to, some are going to apply specifically to school, some are not. And there's a great backside as well, kind of general accommodations. The middle one, Brainstorming Solutions tool, is something that so as someone who worked in a brain trauma unit for a long time, I had this mental template that you develop over the years of when you're listening to someone or working with someone, you're listening for different things, you're looking for different things. And so it's this lists out all of the different cognitive areas, some speech and language areas, emotional and behavioral areas, because all of those could be contributing to what you're seeing, especially when I think about someone who works in a group home situation or in an individual's home. It's great to be able to have a better whole picture of folks, and people who work in the homes often aren't trained in cognition. And so it's a great tool to give them with training in cognition, that they can know what they're looking for and know what the problem is. And then there's a strategies and accommodations tool that goes along with that, again, will just give you an idea of some strategies. It doesn't list every strategy that you can use, but it's really, all of these are ticklers to get you thinking, oh, that's not going to work, but we could try this because this will work for this person because they already do things this way. And then we're going to refer out, talk about referrals now, if needed. So the goal is to use accommodations within your program whenever possible, and try to be successful. If a person with a brain injury walks into your program for your services, that you use accommodations to help them be successful with your content, with your goals. You've seen how pervasive brain injury is. If we all identified people with brain injury and referred them out, they're not going to get your services, and we're going to blow out the other systems that are there. So we really want to try to accommodate within our brain injury program. If necessary, one of the places you can refer out to are the service coordinators. And Rick, I think you can tell us later at the end if you agree with what I just said. The service coordinators really want the cases just that you're really having difficulty with, that you don't know how to access services. The family needs some additional supports. They can't kind of do it on their own. And we'll let Rick talk more to that. Neuropsychologists you can refer out to. They are for more incredible cognitive testing. You will get all kinds of good information from them. They're expensive, and they also are hard to get people into. So you want to reserve that for the people that really need, really just don't know what's going on. And you might refer them out instead to a cognitive rehab program or somebody like that, and see if they can get a handle on things. Where we want the referrals also going is to a symptom specific specialist. So if you know what the problem is, let's say it's a vision problem from the brain injury, then you might refer specifically to a neuro-ophthalmologist. If it's a cognitive issue, you might refer to a speech language pathologist. Balance, you might go OT, PT. And neurologist is good for like headache, seizures. What we've been told by neurologists and by people who refer to neurologists is that they don't always just take concussion, and sometimes it's hard to get in to see them as well. So we want to be getting people to the right people, and then potentially to what I am calling our dream network, where I shown the spotlight on it earlier, of these master's level cognitive screeners. So maybe there as well, if we can develop them, or maybe you just go ahead and you train someone within your own facility. That's awesome too. 2 of our documents specifically have referral options built into it. So this is a great one to hand out to people or to be working with your staff. A guide to possible changes after brain injury, because we know that even after treatment for brain injury, people are likely to still have problems. We haven't fixed everything. So this one is for very young children, and it has what you might see in those children and then who you might refer to. And then this is the same thing for school-aged and adults, where there are some symptoms and who you might refer to, because we find that sometimes people will get lost if you just refer to the general practitioner. Now you might have to, but we really want to get them ultimately into the symptom-specific specialist. Sometimes you can even say, do you think a neuro-ophthalmologist would be helpful when talking with the doctor? Get them thinking in that direction. So some additional resources. Our website, it has so many great documents on it. Some that I've shown, some that I will show are on it. You can go there and just explore. They're broken down by each of our different areas. There's early intervention, there's medical, there's schools, just check it out and you can go in your area. There's also for people who have had an injury, you can send folks there for some resources. We have 2 toolkits that are on the website. We have actually 4, but 2 that are really relevant here. One for survivors, families, and caregivers. There are a lot of tools in here. Too many, because we never know when you're going to be coming here. You might be coming when you've just been injured and you need something, the essential resources and the signs and symptoms. You might be coming because now there's a behavioral problem, or you're returning to school or to work. You need caregiver resources. So there are a lot there. You can help people navigate this. You can just give them what's needed, or you can download the whole thing. As an example, in the family caregiver resources, there are resources on raising a child, raising a teen with a TBI, veterans resources. There's a service professionals toolkit, which is really geared toward the folks that would be on this call and the folks that work out on the, what we'll call the front lines. And it's everything from tools to develop your treatment plans to professional development. There's free professional development in there for more information on brain injury. There's residential resources. Now that's not like typical housing, that's residential with a brain injury, where the brain injury is the big issue there. Another important resource that we feel like should be handed out to everybody who has had a concussion, and we ask doctors to hand out when somebody's had a concussion, is when concussion symptoms aren't going away, because there is a big problem across the country where people are diagnosed with a concussion. They're like, okay, now I know what it is, and my symptoms are going to be around for maybe like 4 weeks or so, and they're going to go away. And that's what people are told, but they don't go away for everybody. And those people are sitting out there, their lives are disruptive, and they don't know what to do. Some can link it back to the concussion, some don't. So we want this in their hands so that they are thinking of it down the line, to be able to go, okay, if I'm still experiencing these things after 4 weeks, then I need to go for help. There are some great guides out there. If I don't talk about one, I'm going to talk about several. If I don't talk about one for your area, just grab one of these, because it's basically the same template, where it's, here's what brain injury is, here's how it relates to this system, here's how we screen, here's how we train, here's how we educate, here's how we modify our program. This is for mental health and substance abuse. It's great. It also mentions, though, criminal justice, domestic violence, homelessness. There are some great domestic violence resources that you can take a look at, and everything that I'm mentioning is in the resource pages, so you can take a look at those. There's a great infographic, except that, and I want to point this out to everybody, we don't let people spend too much time in a quiet, dark room. That used to be the early treatment for concussion. Sometimes you will still find doctors that will recommend that, and then you kind of come out when your concussions are better. You go in the quiet, dark room because usually loud noises and bright lights are a problem early on after a concussion. The research says that will make your symptoms last longer. So we need to be getting people back out into their lives. We don't push them. It's as tolerated, but they can't just sit in that room. They've got to come out and they've got to get back to their lives. Child welfare, we were instrumental in developing this guide. So this addresses the brain injury within the child welfare system, both the children and the caregivers. So where are some places that you can intervene? How do you incorporate the screening there? How do you modify programs, training, educational, and some back to school? This has a ton of supporting materials with it that you can just click on and go through what you might need. Same thing for the criminal justice system, the juvenile justice system, one specifically for substance use. All great. I've read them all. They're all great. The Tennessee Traumatic Brain Injury Program. I don't know if Ashley Bridgman has jumped on. She oversees this program, overseeing the brain links and the service coordinators, also the advisory council, and which anybody is welcome to attend. And they have information on Tennessee sports concussion. You can join the listserv, so you can go there and find that information. This is an awesome tool for justice. It's a national database. Where it has captured all kinds of information on the legal system and brain injury. And you can go in by, who are you looking for? I'm looking for adult corrections. Okay, you can go in that angle and find that. Just an awesome resource. We have included on our resource page fast facts on opioids. We've also included this one on crisis management and de-escalation because we love it and because it was designed for law enforcement. However, if you work with crisis management, if you have situations where you need to de-escalate, then this is just a great resource. Doesn't matter that it was for law enforcement and first responders. Great tips. We have 3 different things that we've chosen on mental health to include in our resource page. And switching now to trainings, we have free trainings on our YouTube training channel. You can get things from like in the 12-minute range to an hour, whatever you're looking for, on a lot of different topics. They are also for specific audiences. And if you don't see your audience, go into something that is similar, whether it's the age or the type of population, and you can just take a look at those. You will find things that are relevant to you. And we are launching a training series specifically for Tennessee Brighter Futures, hoping that we've stirred up some interest in learning more, or at least learning more for the people within your whole system who work within your system. And starting in November, understanding concussion and brain injury will bring some of the intersectionality into that so that they have an understanding of how it relates to what you're doing. Cognitive changes following brain injury. We'll talk about what cognition is, what the different aspects are, and how do you develop accommodations for that. And then we'll talk about, in February, behavioral and psychosocial changes. We'll talk about how do you manage that, and then how do you de-escalate that. We're not going to be coming from the aspect of behavior specialists. Many of you already work with them. We're coming from the perspective of cognition specialists and experts, where we're taking into account the cognitive and the language component of the situation and helping you to put that on top of what you're also learning from your behavior specialists. And that is designed for everybody across all of these systems of support. So we hope that you will sign up for those, and we'll send you out a flyer. Other trainings. So when I talked about blowing out systems, what we would love is for you to attend that training series that we just talked about. We can tailor it just to your population and come out, and usually we have to do most of our work virtually, but give you a training. What we would ask though is that you try to pull in your entire system if possible. So the mental health system, just so that we have enough resources to be able to cover everything. And then we can work with you following any of the trainings to like, okay, now let's get nitty gritty with you. And let's figure out the right screening. Let's answer any questions that you have. What are the problems that you're encountering? Let's give you cases that fit just your population. You know, we can really tailor it there without getting into like a lot of trainings per se. There are other online training resources. These are all in your book, is in your resource pages as well. Lots of great topics. And so an overview in closing. What we're asking you to do in your programs is screen, because we know they are in your programs, people with brain injuries. We're asking you to screen for a lifetime history of brain injury, and then hopefully also screen for cognitive changes. We're asking you to accommodate for cognitive and other brain injury changes within your program, behavioral changes from brain injury. Educate the person and also your staff about brain injury. Incorporate some of the new resources that we've talked about, and also, if needed, seek out additional training for your staff.